while grade obviously historically has been used as a marker indicating poorer prognosis, more proliferative tumors, more sensitive to chemotherapy, it's clear that the MammaPrint assay is a superior prognostic test. So when we utilize MammaPrint, it really further classifies patients into groups that are called high-risk 2 or designated high-risk 1, which all merit chemotherapy treatment, but generally those patients that are high-risk 2 have greater risk of recurrence. And we've just seen from this data set that the MammaPrint is providing more prognostic information than grade alone. The MammaPrint assay is looking at the expression pattern of 70 different genes. So it's got a lot more data points. And I think what we're seeing is that it's just able to further refine that risk stratification above and beyond what grade alone is able to provide. Great question about how we could alter treatment for patients that are MammaPrint high-risk 2 versus high-risk 1, given their differences in prognosis. At present in standard of care, all of those patients are recommended to receive chemotherapy. There has been data indicating that patients with MammaPrint high-risk 2 tumors may benefit more from chemotherapy regimens that contain an anthracycline, comparatively to MammaPrint high-risk 1 tumors, which still benefit from chemo, but may not necessarily need an anthracycline. I think we need more data in that space, but at least data that has been, presented previously from the FLEX registry does indicate that anthracycline benefit is very clear in MammaPrint high-risk 2 tumors. I think one of the other things that we're exploring is whether or not MammaPrint high-risk 2 tumors may benefit from not only chemotherapy, but also the addition of immunotherapy. There's data from the I-SPY clinical trial indicating that if patients have a MammaPrint high-risk 2 tumor, they have greater likelihood of pathologic complete response if they receive neoadjuvant chemo plus immunotherapy. And because of that preliminary data being so compelling and the knowledge that MammaPrint high-risk 2 tumors do appear to have more of an immune active state as opposed to chemo alone. And that's actually the subject of an ongoing clinical trial, the SWOG 2206 clinical trial, which was randomizing patients with MammaPrint high-risk 2 disease to either neoadjuvant chemo alone or chemo plus immunotherapy to see if we can further improve prognosis for patients with high-risk 2 disease. That was really the rationale for the SWOG 2206 clinical trial, which is now ongoing. We are about a third of the way accrued on that clinical trial. So ultimately about 300 patients enrolled, with a goal of enrolling 900 patients to answer the question definitively about whether or not immunotherapy benefits patients with MammaPrint high-2 tumors. So we're really eagerly awaiting that data to help us understand whether or not it might change practice. And if it looks really compelling, it may be in the future that we are moving toward treatment of MammaPrint high-risk 2 disease, very similar to a paradigm that we use in triple-negative breast cancer.